Good afternoon, folks. Now, today's topic is a world solution to the geriatric mental health crisis. Here we go with today's presentation. Please sit back and enjoy. Okay. In rural America, the geriatric mental health crisis is not looming. It is here. It is visible in the window. Who tells me she hasn't spoken to another person in days? In the retired former no. Who stopped going to church after his wife died, and the older man who insist he's fine, even as he quietly stops eating, stops driving, stops caring. These are not isolated stories. They are warnings, and we are ignoring them. Rural elders living longer with fewer supports than ever before. They carry grief and that compounds over years, anxiety about becoming a burden, and depression that hides behind stoicism. Many have lost spouses, friends, neighbors, and the roles that once gave their days meaning. When they finally reach for help, they find a system that is simply not there. The newest mental health clinician may be an hour away. Broadband is unavailable or unreliable. Primary care practices are overwhelmed. Transportation is limited, and stigma still keeps too many older adults silent until the suffering becomes unbearable. This is not a natural consequence of aging. It is a policy failure, and it is preventable. Rural communities have the ingredients for a solution. Trust, proximity, and culture of showing up for one another. What they lack is the infrastructure and the investment to turn those strengths into functioning mental health system. We need mobile geriatric mental health teams that bring care directly to the kitchen, tables, churches, basements, senior centers, and front porches where older adults actually live. When clinicians come to them, elders open up about the loneliness, that settles in after sunset, the memories that keep them awake, the fear of losing independence. These conversations prevent crises. They prevent hospitalizations. They prevent deaths. We need to integrate. We we need integrated primary and behavioral care because primary care is often the only door rural elders walk through, embedding mental health clinicians into rural clinics on site or virtually makes suffering visible and treatable. And we must invest in the trusted local anchors who already form the emotional infrastructure of rural life: pastors, pharmacists, librarians, Meals on Wheels, drivers, EMS volunteers. They are all first to notice when someone stops showing up, stops answering the phone, or stops being themselves. With basic training, they can recognize early signs of distress and connect elders to help long before a 911 call. These are not optional enhancements, they are the minimum standard of human care. Policymakers must act now. Congress and state legislators should expand Medicare reimbursement for home based mental health care, fund mobile teams and community health workers, strengthen rural workforce incentives, and invest in broadband that actually works for older adults. Every delay has a cost. Every year we wait, more more rural elders slip into isolation, crisis, and preventable decline. The question is no longer whether we can afford to build a rural mental health system for older adults. It is whether we can afford not to. Rural elders are not unreachable. They are simply underserved by systems that have never reflected their lives. A just society does not abandon people because they live far from city centers. A moral health system does not wait for suffering to become catastrophic. before it responds. We know what works. We know what role elders need. The only missing ingredient is the will to act. Okay, guys, that is A for you. I'll be back on shortly with B. Give me a bit for that, please, and I'll be on with that for you. For now, Gator Wellness, take care, folks.